Today, I want to talk to you about interviewing a patient with headache. Some students struggle to make the transition between the classroom and the clinical environment. This presentation is designed to make that change more meaningful for you. You and I will be interacting throughout this video. So let's begin. We will begin with a patient with headache. A 45-year-old female complains of headache for one day. Now, this is the chief complaint. The chief complaint should include the age of the patient, the sex of the patient, the main complaint, and the time of onset. The next step is the history of the present illness, the HPI. HPI means history of the present illness. I am now going to get information about this headache that will allow me to start formulating possible causes for the pain. The first thing I want to know is the onset of the headache. Number one, did it start suddenly? If it started suddenly, did it reach a maximum intensity within seconds? Also, did it start gradually and slowly reached a maximum intensity over minutes to hours? If indeed it started suddenly and reached a maximum intensity within seconds to minutes, you should consider a ruptured aneurysm. The next thing I want to know is the quality of the headache. So I ask, what does the headache feel like? First, is it a throbbing pain? Throbbing pain suggests migraine headache. Or is it a squeezing pain? This suggests tension headache. Or is it a pressure-like pain? This suggests a tumor. Or is it a sharp pain? This suggests scalp pain. Or is it a loud thunderclap followed by headache, which would suggest a subarachnoid bleed due to a ruptured aneurysm? And then, is it a dull, non-specific pain? This suggests stress-induced headache. The next thing I want to know is the activity prior to the headache. So I ask, what were you doing moments before the headache started? First, headache that interrupts sleep suggests a tumor. Next, headache that starts during or after sex suggests subarachnoid bleed as a result of a ruptured aneurysm. And then thirdly, headache that occurs after significant head trauma suggests an extraaxial bleed. And extraaxial bleeds are subdural, epidural, and subarachnoid. The next question is, where is the headache located? Is it frontal? Is it occipital? Is it temporal, or is it parietal? The next thing I want to know is the frequency and the pattern of the headache. So I ask, does the headache comes in a cyclic pattern and reaches a peak each time? If that's the case, think of a slow leaking subarachnoid bleed that seals off itself and then rebleeds. When it bleeds, the headache peaks, and when it seals off, the headache subsides. So be very suspicious of headache that has a cyclic pattern. In terms of the frequency, if the patient states that she had the same type of headache on previous occasions, then it is less likely to be life-threatening. However, let caution and diligence guide you when the patient states that she has had the same type of headache before, because this might just be a new pattern that has life-threatening outcome. The next thing is a series of questions that should also be asked with the headache. Number one, does light bother your eyes? If the patient says yes, this suggests migraine. Next, does the headache improve if you go into a dark room or cover your eyes with a towel? If the answer is yes, this suggests migraine. Is the headache throbbing? If the answer is yes, this suggests migraine headache. And fourthly, do you have rhinorrhea or lacrimation on the same side of the headache? If the answer is yes, this suggests cluster headache. The next thing I want to know is a medical condition. Persons with uncontrolled hypertension can have a parenchymal bleed, which can cause headache. Persons with lung cancer can have headache due to metastasis to the brain. Persons on anticoagulant can have headache if they sustain moderate head trauma. And persons on medications that block the smooth muscle receptors in the vasculature may develop headache due to throbbing that results from vasodilation. Before completing the history, I want to know if any of the following was associated with the headache. Number one, nausea. Number two, vomiting. Number three, blurred vision. Number four, double vision. Number five, slurred speech. Number six, weakness or numbness in the upper or lower extremities. Number seven, dizziness. And number eight, an inability to walk. Now let's look at a case. Here is the full story. This is a 45-year-old female complaining of "my head hurts for 5 hours," in open and close quotation. The patient states that while she was at home watching TV, she developed the most excruciating left-sided headache. The pain started suddenly and reached the maximum intensity within seconds or minutes. She describes the pain as a steady ache with associated weakness in the left arm. She has had 2 episodes of vomiting and has never had this type of headache before. Notice that from the history of this patient, the most likely diagnosis is a ruptured aneurysm. The 2 most important components are the sudden onset of the headache and the maximum intensity within minutes. Here are a few things to keep in mind. Number 1, headache can be classified as primary and secondary. Number 2, primary headaches include migraine, cluster, and tension. Number 3, secondary headaches include headaches that are the result of an event. For example, ruptured aneurysm is the event that results in excruciating headache. And lastly, it is very possible to have a normal neurologic exam even when there is cerebral pathology. The size of the pathology and the location of the pathology will determine the neurologic manifestation. So let's summarize. What needs to be included in taking the history of a patient with headache? Number one, the onset of the headache. Number two, the quality of the headache. Number three, the intensity of the headache. Number four, the activities prior to the onset of the headache. Number five, the location of the headache. Number six, the frequency of the headache. Number seven, previous episodes of the headache. And number eight, associated features and any neurologic deficits that the patient might describe while taking the history. Well, thanks for watching. I do hope this presentation was useful and will allow you to improve your history taking skills concerning patients with headache. Please remember to like, share, and subscribe. I wish you well. Good night.